your weekend pleasure, I posted a quiz to Blackboard. Let's do mine.
You did. I was fixing to give you some muscle carbs.
That's not even.
Why are you laughing? It's not funny.
I think that's because we all gave him a look like. Really?
We hate you for our lipstick pill.
All right, so in an effort to enhance your learning experience, I've got this app right here that once I press the little red button, it will start recording my voice, and it will also allow me to write directly on the PowerPoint, and then I can save it as a file, and then I can, this is the free version, so it has to go up to YouTube, it has to go to someplace public, so I'll post it to our YouTube account, and then you can have my smiling face, and then you can have, let me know how it works with this. I'm kind of concerned about the audio.
Sounds like a skeleton.
So we're gonna see you and the telephone?
We ain't gonna hear you
Two
say
separate
naked or
things.
nothing, or are we?
She's folded the bag. We have everything.
All right, so the shoulder joint.
131.
Let's look at the objectives. Can you perform objective number 1 there? Perform and identify joint motions of the shoulder joint.
Perform all of them.
So let's do shoulder flexion as a group, shoulder extension as a group, shoulder abduction as a group. Don't forget to externally rotate.
Or
Yep.
if you don't have to, don't.
Most people do though. A deduction. Very good. That's reference from here. Oops, here's neutral. External rotation. Or, who said that? Who said that? Medial rotation or internal rotation. I'm missing 3. What are they?
Oh.
Horizontal.
Horizontal abduction, horizontal abduction, and circumduction. Because it can truly circumduct, what's that tell you about the joint structure? Triaxial, what's that tell you about the joint structure?
Not very stable.
Not very stable.
That's not very stable,
But mobile.
but mobile. What else does it tell you about the joint structure? What type of joint is it? It's
Ball and socket.
Ball and socket. Identify the bones and bony landmarks of the shoulder joint. Josh?
Sorry.
Identify
you are.
the bones isn't that slicker? Oh, get out.
Neo and torpedo, page 130.
What is
Your humerus,
humerus,
scapula,
scapula,
clavicle,
clavicle,
your bony landmarks, the chromium process, clavicle, head of the humerus, coracoid process, spine and scapula. That's all I can think of. Inferior border, superior border,
how about angle?
angle,
Superior and inferior angle.
here, vertebral border is what I was thinking of.
Ball and socket, humeral head articulating with the glenoid fossa of the scapula. This is a synovial joint, and that will be very important to understand. And as Blake pointed out, it's the most movable joint in the body, but it's one of the least stable.
So,
I said movable.
so, Joshua.
He said so.
Don't be be trying to
That was
build
50-50.
Blake's thunder, he don't ever get into
Hey,
it.
it's
So,
Bonnie and
we've already
Clyde.
got, we did flexion extension, we didn't talk about hyperextension, but everybody knows what, this is flexion, return to neutral is extension, and then pass from neutral back is hyperextension, according to Lippert. Now, you will be tested in this class according to your textbook. Right? Abduction, adduction, medial and lateral rotation, horizontal abduction, and one thing that they left off.
In the book, it talks about scaption. Is that something you ever use?
Yes. Scaption. Anybody want to tell me what muscle is primarily active during the motion of scaption? No. No. No.
Rectus femoris.
No. What did you say back there?
Rectus
The subscapularis? No. Say it, say the name of that muscle. No. No.
Supraspinatus.
We keep naming these muscles, and we all know that you know all the muscles that surround the shoulder complex. You missed out on a
Upper tract?
Oh my gosh!
And what was the question?
What muscle is the primary mover or a primary mover for scaption?
What is scaption? Is that a
Page 132 of the book.
We called scaption in A&P for PTAs abduction in the scapular plane. Thank you.
I thought somebody said that.
I said that.
Speak up.
Right after us.
I heard it like twice. Jim said infraspinatus, and I
I thought it was gluteus
You
medius.
gotta speak up too.
In the femoral triangle.
said.
At least I was an idiot on purpose.
So flexion, extension, hyperextension,
I deal with that one too.
flexion,
I was gonna sound like an idiot.
hyperextension, abduction, circumduction, external rotation, internal rotation, horizontal abduction, horizontal abduction.
So in scaption, you trying to fly or something?
Scaption is not at here. Scaption is not in the frontal plane, it is not in the sagittal plane, it is in the scapular plane.
Oh, okay, I got you.
Now, why did we call this? Yes.
I remember that now.
Remember, it's called the scapular plane because the scapula does not fit flat on posterior ribs. It sits at an angle, and the glenoid fossa doesn't point straight this way, doesn't point straight this way, it points that way. And that's where you get a straight line of pull. That's scaption. Now, everything that we've been seeing in practice exams, we saw the picture the other day where showed the girl pushing out here like this, she was abducting. It was straight plane abduction. It said what muscle is active, and the answer was supraspinatus. We all got it right, right? So, most of the time, I don't think they'll see it as abduction in the scapular plane or scaption. They'll just say abduction to some degree.
I have a question though. This says 30 degrees. Isn't it 45 then?
For what?
Section.
What page are you on? I didn't bring my book.
132. It does say 30 degrees in the forward of the frontal plane.
Approximately.
Yeah, approximately.
It says not quite midway.
Yeah, it's about like this. About like this.
It's like calm down people before he gives his speech. The great Pontius Obama.
It's just lateral to hip
Oh, all right, wait, are you saying 30 degrees,
It's saying, it says 30 degrees.
not active to 30 degrees?
Since scapular pain is approximately 30 degrees forward.
Yeah, it's right back here. Somewhere in between. I'm not gonna get that technical. You just need to know scaption is the supraspinatus, and it's not in the frontal, it's not in the sagittal, it's in the scapular. Woo! Right. All of these motions, right here, flexion, extension, and hyperextension, remember, are in the sagittal plane and the frontal axis. Yes, I will ask you questions about that. In the frontal plane sagittal axis, abduction and adduction. Transverse plane, vertical axis, external, internal, horizontal ABD and horizontal ADD.
Are you wanting to know the degrees on these also?
Considering that we have already tested over the glenohumeral joint in lab, yes, I will be expecting that you know degrees.
We're talking about normal range, what degree are you talking about?
Normal range. You have to know normal range so you can recognize abnormal range. And a combination of all the motions is circumduction. Right there. What other joint can circumduct?
Yeah, that's one other one, because
Is
it's,
it femoral?
Is this the only other ball and socket joint?
Femoral joint.
I got one answer or what?
It's more like a femoral articulation.
The femoral
Right.
angle.
The scapular landmarks, Josh already
Beat it.
expounded upon. I need to, I'm gonna do this, dipsticks. What is this right here? What,
Yeah, I mean,
what is that?
anterior.
This right here is the inferior ankle. What's G pointing to right here? Roman process. What is the blue line pointing to right here? Coracoid process.
Blake can't find it.
What is E pointing to? Thank you. H. What is A? The glenoid process. And F,
labor.
You gonna do it red?
She said it first.
it's the labrum.
I don't wanna take credit.
We had a brief discussion over that the other day.
Still got it up there.
How it deepens the relatively flat glenoid fossa. One of the other things it does is it also helps to provide a negative pressure in that joint space to help hold the humeral head in place. That's why when you have one of these labral lesions, like I drew up there on the board, you lose that suctioning ability.
What is the scapular grill function? Does it help stabilize the shoulder because it has so much motion?
Yes.
Okay, because thinking about that, man, could you live without it?
It provides an attachment for the humerus, basically.
Okay.
Get down to the very bottom of it, gotta have somewhere for your arm to attach to.
Right.
All right. What is this whole area right here called? The subscapular fossa. What is D?
Supraspinatus fossa.
That's not, don't take that supraspinatus, take the S off and replace it with us, supraspinous.
Okay.
What's C there? Infraspinous fossa. G is, what is this arrow pointing to here?
Scapular spine.
Spine and scapula. Very good. I taught you your anatomy well.
We can read the book pretty good.
Leave me with my fantasy.
Hey, you really went hard in the ligaments the other day. Is that something we're gonna have to really get up on, the ligaments? Cause that ain't something we've covered before when we was talking about the shoulder.
I need you to be familiar with them,
Mm.
because when we talk in Therex too about rehab,
Cause you injure them a lot, the ligaments or something? Or-
you don't injure them a lot, but you do injure them, and it's, since it's on one of your most mobile joints in your body, it's pretty significant. when you do
Okay.
it. All right, do we need to review over this? Don't be ashamed to say yes if you need it. No?
Fair. You wanna volunteer to lay there? $2 million.
What you really need to know about this one right here,
What in the world? Amy.
She's looking like.
Oh.
This is a delayed print, I did it.
No, yeah, I'd say too,
Hey, you haters be hating.
is this bony protuberance here, and this bony protuberance here. The greater and lesser tubercle. Because they are essential points of muscular attachment for muscles that rotate the humerus. They also form the bicipital or intertubicular groove in which the long head of the biceps goes through.
I like playing with my bicep with you.
What I want you to notice
Not
right
as
here,
much as my.
let me change colors. Let's go with a hot pink.
It is breast cancer. It is cancer awareness. It's hot. You girls.
That's obviously fuchsia.
Fuchsia purple, hot pink. G, what does G point to right there? Deltoid tuberosity. What inserts at the deltoid tuberosity? Duh. Deltoid. What I want you to notice is how far down the humerus it actually is. Yeah, it's long, it's at least halfway.
What are we talking about now?
I noticed that.
Worthless. You guys are worthless today.
Apparently no one's feeling it.
It's
Well, we
big.
didn't break.
It's not
We thought break.
bad.
We thought fall break started at 10.
You've had a few stressful weeks leading up.
We got short timer syndrome, baby.
A few stressful weeks. How about 8?
Oh, come on. It's not
All right.
all that bad.
Yeah, exactly.
Now looking back.
There went the sympathy when you went too far.
Yeah, way to go.
What color do you prefer there?
Lime green.
Let's try black.
There we go.
How about yellow?
Line through it, you're not supposed to read it, Jack.
All right, right, so these are the structures that you should be you're familiar. These are the structures you should be familiar with.
Those three are all,
All of them.
I mean, I realize we know them all, but I was just saying like, really. Never mind.
All right, what type of joint did we say this was? All right. So the joint capsule. Tell me what you know about joint capsules and synovial joints.
Actually, shock absorber.
I got pieces and parts of the whole thing. So somebody put it all together for me, Scott.
Right after the shock absorber.
It's encapsulated.
Encapsulated. Thank you, Scott.
All right. Blake, bail him out.
Oh, God. Shock absorber? Does it hold the synovial fluid?
Yeah.
I know that. And the shock absorber, is that what else is it?
Annie, bail these jokers out.
It contains synovial fluid that, lubricates the joint bone.
Keep going.
It's encapsulated. Different? I don't know what you're trying to.
Chris, tell me what you know about a synovial joint capsule.
It is enclosed, it produces synovial fluid that nourishes and lubricates the joint. It's avascular, I believe. Or it is vascular. There's a fossa. I mean, a label.
What'd he say? A fossa?
There's a fall.
I mean, it's around, it's inside.
All right, so a synovial capsule
The bones don't touch, right? That's not what it's doing.
is around articulating bones that are movable. Synovial capsule has two layers, an outer fibrous layer for integrity and protection, an inner membranous layer for secretion of synovial joint for lubrication and nutrition. It has bone ends in it that are covered by hyaline cartilage, which are avascular, Scott. The hyaline cartilage is, not the synovial joint.
Yeah.
But on the knee, you said the inside of the capsule is avascular and outside is vascular.
No, I didn't. We can make a bet.
The ligaments.
The ligaments.
Inside, the ligaments themselves are avascular. The joint capsule itself is not avascular.
Now, the outside is not the
So
inside.
the ligaments outside of the capsule are vascular and inside are avascular.
That's why you can tear those and they usually don't have to repair them like your
Question
MC, like you said.
Yes. The intracapsular ligaments of the knee, i.e. the ACL and PCL, are relatively avascular. They rely on getting their nutrition from synovial fluid, which comes from the synovial joint, which the synovial joint itself, the membranous and the fibrous layer are vascular.
So the intercapsule isn't, but the capsule on the outside itself
The
is?
capsule itself is vascularized, yes.
Okay,
But the ligaments inside of it
Are
are
not.
avascular.
so the ligaments and the cartilage within it is not.
Right.
Well, they don't need to be though, because they're surrounded by.
Synovial.
That's what Scott meant when he said avascular, just within. He's not buying it very well.
Tried bailing you out, but yeah, I'm not buying it very well.
It's all coming back to me.
All right, so this particular joint capsule, thin-walled, spacious container. This is the operative word, especially at the glenohumeral joint. attaches around the rim of the glenoid fossa, scapula, anatomical neck, and humeral neck. That'll be humerus. Oh, look, outer fibrous membrane, inner synovial membrane. Now, here we go. This is important information.
Yeah, you can't see the bottom.
I thought you were joking, you were crossing it out.
No, this is very important information right here, because it relates to a lot of pathologies that we see at the humerus.
Okay, you went backwards,
What's that?
you left.
You go back forward.
I went forward.
Oh, we didn't, okay.
It's
Arm hanging
on
at
page 134.
134.
Yeah.
I can't find it.
So would that become like a
It's at
sublet?
the bottom of the joint capsule.
Don't get me chasing rabbits yet.
Oh, okay.
That answer will become evident
Where'd you see it?
directly.
Rabbits in a cage.
I'm trying to.
All right, so, let me tell you the reason why it's taught with the arm hanging, the superior portion is taught while the arm is in the anatomic and or fundamental position, and why in the inferior is slack and it reverses when we go into flexion or abduction. Right? It all has to do with these ligaments. This ligament right here
You need to make a shoulder. We can project. It's really hard.
Right, so A is the coracohumeral ligament. Coracohumeral ligament. What two bones does it attach? Tara?
The humerus and the, however you say that? Whatever. Say, I can't say it. The coracoid, is that how you say it? I don't know.
What do you mean you don't know?
I don't know.
Coracohumeral ligament, right? That was, so it's coraco.
Yes, it is the coracoid process.
Scapula.
You get the next question to redeem yourself. Then the glenohumeral ligaments. You have three. You have the superior glenohumeral ligament. You have the middle glenohumeral ligament. And you have the inferior glenohumeral ligament.
But if they're taut and slack, if it's just A and B, that'll be taut and slack for the most part.
Yeah, actually, the superior and middle glenohumeral ligaments, they kind of stay the same the whole time.
Okay.
I mean, this is the tendon of the long-headed biceps, by the way. All right. Glenohumeral ligaments, what do they attach? What two bones do they attach? And the humerus, yes, the rim of the glenoid fossa. Now, is this something that needs to be turned in?
That's kind of,
Does it need to be turned in?
not for me,
Oh,
if you
okay.
just look at it too.
So this inferior glenohumeral ligament is actually very loose, and it is shaped a bit like an accordion. Let me get this accordion done here.
Like the things we used to make in school. Yeah, it reminds me of the little fans that we would make.
sacrohumeral ligament here, glenohumeral ligaments here. Okay, let's do it like this. Superior glenohumeral ligament, middle glenohumeral ligament, inferior glenohumeral ligament. Inferior glenohumeral ligament actually comes down and forms the inferior part of the synovial capsule, and it looks like this. That inferior capsule kind of hangs down and is baggy, and whenever you flex or abduct, what this does is it goes and then folds back like this. So come into abduction. So we'll do that.
So that hard part is right there?
That's your humeral head.
That's the bone?
Alright, so what can happen is you can get a problem called adhesive capsulitis. And adhesive capsulitis is an inflammatory response occurs for whatever reason. Some people just, it's idiopathic, they don't know what causes it. And you get scar tissue that lays down in between here. And it's kind of like if I were to do this, abductor, that castle seizes up. You guys wanna come and teach? You sure?
Go with me?
Yes.
Is like the superior, like a string out over the top then, so when you're down, it pulls it tight?
We'll start this over Monday. I'm wasting your time and you're wasting mine. Let's move on. You guys are toast. We'll enjoy a long lunch, get ready for a good long weekend.